Imagine this: a high speed car crash, maybe a devastating fall, just a really severe injury that shatters bones and rips through tissue. The immediate aftermath is pure chaos. Flashing lights, adrenaline, and that desperate fight for life. You see the external wounds, the obvious trauma. But here's where it gets really interesting and quite alarming. What if I told you that the most dangerous enemy, the most insidious threat, often emerges not in those chaotic first moments, but days later? It's this hidden adversary within the body.
It's a silent struggle, and it can be far more deadly than the initial injury itself. It's a profound challenge in medicine, isn't it? The very systems designed to protect us to heal after that initial blow can sometimes turn against the body, leaving it incredibly vulnerable to a new invisible invasion. And that's precisely what we're diving into today.
Welcome to The Confident Nurse. I'm Andrea, an ICU trauma nurse for nearly 2 decades, here to share the insights I wish I had earlier in my career. And with me is Nate, ready to ask the tough questions and keep things interesting. Our mission today is to unpack a critical, often misunderstood, and a profoundly dangerous medical condition: trauma induced sepsis. This isn't just some generic medical term, it's a life threatening organ dysfunction specifically triggered by a dysregulated or maybe out of control response to infection after a significant traumatic injury.
Yeah, and that distinction is absolutely crucial. It's not simply an infection happening in a trauma patient. It's the body's overwhelming and harmful reaction to an infection that arises in the aftermath of that trauma, and its severity really cannot be overstated. When you look at the numbers, it's pretty startling. And
This condition is a leading cause of preventable mortality after trauma, especially once patients get past that initial, say, 48-hour period. In some regions, it accounts for, well, up to 30% of all sepsis cases in the ICU, like the silent epidemic within trauma care.
30%, that's a huge proportion, and it really highlights that hidden burden you mentioned. So, for you, our listener, the goal of this podcast isn't just to define trauma induced sepsis. We want to understand the intricate how and why. How does a severe injury actually set the stage for this catastrophic, almost self sabotaging immune response? Why is it so frequently missed in those absolutely crucial early stages? What specific time sensitive actions can truly save lives when every minute literally counts?
And we'll go even further than that. We'll explore how patient care extends far beyond the acute immediate phase, delving into the complex journey of long term recovery. We'll also tackle critical systemic challenges like how unconscious biases in healthcare can affect treatment and why seamless teamwork among healthcare providers is not just helpful, but absolutely essential for survival and recovery.
Okay, to really wrap our heads around what happens inside the body, let's use an analogy. Think of the body after a major trauma, like a powerful ancient fortress. Its mighty walls have been breached by the initial attack. That initial injury is the visible assault, the crumbling stone, shattered defenses. But then, the fortress's own loyal soldiers' internal defenses become confused. They might either turn against the fortress itself in a chaotic frenzy, causing more damage from within, or they become mysteriously weakened, disorganized, leaving the fortress incredibly vulnerable to a new silent invasion from within, maybe, or from outside. That new invasion, that's the infection, and the resulting chaos when the body's messed up response to it. Well, that's trauma induced sepsis.
That's a vivid way to put it: a fortress battling itself. It truly captures that internal battle that can be far more devastating than the initial external damage.
Right. So let's start by looking closer at this invisible enemy and the intricate biological dance, the paradox that sets the stage for it. Okay? Let's unpack this a bit more. We've given it the name trauma induced sepsis, but what makes it so distinct, so tricky compared to, say, sepsis from pneumonia or a simple UTI? Is it just about timing?
The nuance here is absolutely critical. Yeah. It's not just any sepsis that happens to occur in a trauma patient. It's sepsis that either directly originates from the traumatic injury itself. Imagine an open wound getting infected, or maybe a severe internal injury causing a leak in the gut that leads to infection. And this is the really key differentiator, it's sepsis, where the body's response to the initial trauma significantly changes its immune system. It makes it far more vulnerable to infection and less able to fight it effectively when it does happen. This specific distinction really helps us zero in on how we recognize it and, importantly, how we treat it.
And part of that trickiness, I imagine, is actually spotting it in the first place. Trauma patients already have so much going on, right? So many expected symptoms. It must be like finding a needle in a haystack.
Precisely, that's its deceptive nature. Consider the early signs of sepsis, maybe a low grade fever, a rapid heart rate, or perhaps a change in mental status where a patient seems confused, less alert. Now, here's the challenge these are often perfectly normal symptoms after a major trauma. A patient might have a fever just from the sheer inflammatory response to their injury and not necessarily an infection. They could be tachycardic, have that rapid heart rate purely due to pain, blood loss, or maybe shifts in body fluids and altered mental status. That could easily be from sedation, pain meds, or even a subtle head injury. This significant overlap can be incredibly misleading. It can lead to critical and potentially fatal delays in diagnosis and treatment.
So you're saying these aren't just subtle symptoms, but they are actually mimicking other expected post trauma symptoms. That's a huge challenge for clinicians at the bedside. Can you give us an example? How does this play out in the real world? How can these critical clues get missed?
Absolutely. Module 1 includes a really poignant case study. A patient, let's call him Mr. R. He was 43, suffered multiple severe injuries, a pelvic fracture, a liver laceration, bad stuff. On day 3 after his injury, the nursing staff noted he developed a low grade fever and tachypnea. That's rapid breathing. Now, as we just discussed, these are classic early signs of sepsis. However, in Mr. R's case, they were unfortunately dismissed, attributed to his severe pain, the body's general response to injury. No specific lab tests for infection were drawn, no blood cultures taken. By day 5, just 2 days later, his condition dramatically worsened. He decompensated directly into septic shock, a much more severe, life threatening stage. This scenario just painfully highlights how critical clinical suspicion is, especially when you're dealing with what seem like subtle symptoms in a complex trauma patient. It's a constant battle for the care team to differentiate.
So it's not just the external wounds, but the body's internal response to trauma that seems to, well, betray it. This idea of an immune paradox, from what I understand, is truly fascinating and deeply concerning. How exactly does the immune system, designed to protect us, go so awry after such a significant injury?
That's an important question. And Module 2 really dives into this. Trauma doesn't trigger just one simple, straightforward immune response. No, it sets off a dual, almost contradictory cascade of events that can put the patient in a really perilous state.
Okay, let's break those down. The first phase sounds incredibly intense, like a storm.
It is. Immediately after a major injury, the body launches into what we call hyperinflammation. It's often referred to as a cytokine storm. Cytokines are these powerful chemical messengers that immune cells use to communicate. In this phase, there's a rapid, incredibly intense release of specific inflammatory cytokines molecules like IL-6, TNF alpha, IL-1. Think of these as the urgent alarm signals mobilizing immune cells, particularly neutrophils. They're like the body's first responders to the site of injury. This causes widespread inflammation throughout the body. Clinically, this extreme inflammatory state often presents as systemic inflammatory response syndrome, or SIRS. You'd see typical signs like fever, a rapid heart rate, maybe an elevated respiratory rate, abnormal white blood cell counts. Up to 85% of trauma patients admitted to the ICU meet SIRS criteria purely from the injury itself. No infection present yet. So differentiating true infection from the body's natural, though extreme trauma response, incredibly challenging.
Okay, so the body goes all out, a full scale assault against the trauma. But then you mentioned a second, quieter, and perhaps even more dangerous phase. That sounds counterintuitive. Why would the body dial down its defenses when it's most vulnerable?
That's the paradox. That's the aha moment in understanding trauma-induced sepsis. Hours to days post injury. After that initial hyperinflammatory storm, the immune system tries to rebalance itself. But in many trauma patients, it overcorrects. It swings too far the other way, leading to a state of immunosuppression, sometimes called immune paralysis. This means the body's ability to fight off new infections is significantly reduced. It's almost as if its defense system has been temporarily shut down or just completely exhausted. Key immune cells like monocytes and T cells, which are crucial for identifying and destroying pathogens, become impaired. This makes the patient incredibly vulnerable to even minor infections that, they would normally easily fight off.
So they could be simultaneously inflamed and suppressed. That sounds like a recipe for disaster. The body is essentially sabotaging itself by being both overly aggressive and then overly weak. That's the real hidden danger here, isn't it?
Precisely. This immune dysfunction creates a critical window, a period where a new infection, even one that seems minor, can gain a significant foothold and rapidly develop into full blown sepsis. What's particularly deceptive is that a patient can fluctuate between these two states or even experience elements of both at the same time. This means that even if those initial inflammatory markers, like the white blood cell count, seem to normalize, the patient is still incredibly vulnerable. The key insight here is that the body isn't just reacting to the injury. It's undergoing a profound immune shift that drastically alters its ability to fight infection, often when we least expect it.
How do you even spot this quiet but dangerous immunosuppression if the typical signs of inflammation, like a fever, aren't even there? What are the subtle clues clinicians need to look for?
That's where clinical diligence becomes absolutely paramount. You have to look for the subtle, often counterintuitive clues, things like a patient who doesn't mount a fever despite a suspected infection, or someone who has persistent leukopenia. That's a dropping white blood cell count when it should ideally be rising to fight an infection. Other signs can include a general apathy or lack of responsiveness, a prolonged ileus. That's a temporary paralysis of the intestines signaling systemic distress, or even unexplained glucose variability, meaning their blood sugar levels are swinging wildly without an obvious cause. Module 2 specifically points out that lymphopenia, a low count of lymphocytes, those specialized white blood cells, the commandos of your adaptive immune system, strongly correlates with this immunosuppression. These are the quiet red flags, the unusual patterns that clinicians really need to recognize. Who's on the hot seat? High risk trauma populations.
Okay, if the body's immune system can be so unpredictable after trauma, it stands to reason that certain people or certain types of injuries are going to be inherently more vulnerable than others. Who's really on the hot seat when it comes to trauma induced sepsis?
That's an excellent question. And recognizing these high risk groups is absolutely key to proactive monitoring and, well, early intervention. First, let's consider the injury types. Polytrauma, meaning multiple severe injuries affecting different body systems, significantly increases the inflammatory burden on the body. It's like throwing multiple wrenches into the machine at once. Penetrating injuries, stab wounds, gunshot wounds, and open fractures where the bone actually breaks through the skin. These are particularly dangerous. They create direct pathways for pathogens, bacteria, and other nasty bugs to just walk right into the body. That drastically elevates the risk of infection and subsequent sepsis.
And what about the patients themselves? Does age or their pre existing health play a significant role?
For sure, when we look at patient demographics and comorbidities, several groups definitely stand out as particularly vulnerable. Geriatric patients, for instance, older adults are highly susceptible. They often come in with pre existing conditions like diabetes, which impairs immune function, or chronic obstructive pulmonary disease, which makes them more prone to lung infections. More importantly, they experience immunosenescence. That's a natural age related decline in immune function. It means their body's ability to mount a robust defense against new infections is inherently blunted. This can mean they have a blunted response to infection. They might present with hypothermia, a low body temperature instead of the classic fever, making sepsis even harder to detect.
That's a critical point, hypothermia instead of fever. So the usual red flags aren't even there. Wow. How about burn patients? They seem like they'd be extremely vulnerable too.
Oh, absolutely. Burn patients suffer massive loss of their skin barrier. That's our body's primary physical defense against pathogens. Gone. This extensive injury leads to sustained body wide inflammation and a very high rate of invasive lines. Central lines, urinary catheters, breathing tubes, all of those are potential entry points for bacteria. This devastating combination just significantly elevates their risk.
And what if someone already has a compromised immune system before the trauma even occurs? Say they have HIV or cancer.
Then the risk is exponentially higher. Patients who are already immunocompromised, perhaps due to HIV, active cancer, or those on medications to suppress their immune system for organ transplants, they might not be able to mount a classic inflammatory response at all. Their white blood cell counts might not rise as expected. They might not develop a fever. Sepsis becomes incredibly stealthy in these individuals. Close monitoring is essential. And finally, we have to consider orthopedic hardware. Things like pins, plates, external fixators used to stabilize broken bones. Unfortunately, these can become colonized with bacteria. These bacteria can form biofilms, protective, slimy layers that make them notoriously resistant to antibiotics. The hardware itself can become a persistent hidden source of infection.
So, what does this all mean for someone listening, perhaps for a family member, or just to be better informed about healthcare in general? What's the takeaway?
It means that knowing these specific risk factors allows for a heightened sepsis radar. If you or a loved one falls into one of these high risk categories after a trauma, it just underscores the need for really proactive monitoring and an elevated level of clinical suspicion from the care team, even when symptoms appear subtle or atypical. It's about anticipating the potential threat before it fully manifests.
Okay, so we've talked about how trauma sets the stage and how difficult this enemy is to spot. Now, let's get into the fight. Once sepsis is suspected, what happens? I've heard the term golden hour in other medical contexts, like stroke or heart attack. What does it mean for trauma induced sepsis? Is it just as critical?
The golden hour in sepsis isn't just a catchy phrase, it's a matter of life and death. It is an absolutely critical window for intervention. Module 3 gives us a pretty grim statistic that really underlines the urgency. Mortality increases by a shocking 7.6% for every single hour of delay in antibiotic administration once septic shock sets in. That's when the blood pressure drops dangerously low and organs start failing. So, yeah, speed truly saves lives because the patient's body is quite literally deteriorating with every passing minute.
7.6% per hour. That's a really concrete and terrifying number. So, what are the critical components of this hour one bundle? What absolutely has to happen within that first 60 minutes?
There are 5 core time sensitive interventions that are absolutely non negotiable. First, and this is crucial for guiding later therapy, you need to draw blood cultures first. Get 2 sets of blood cultures from different sites, ideally one from a peripheral vein and one from a central line if the patient has one, before you administer any antibiotics. This helps identify the specific bacteria causing the infection later on so you can fine tune treatment. It's about getting the sample quickly, not waiting around for results before starting treatment.
Right? So, it's not about waiting for the results to come back from the lab, but just getting the samples taken promptly so you can get the patient started on the right treatment path immediately.
Exactly. Don't delay treatment waiting for results. Just get the samples drawn quickly. Second, and this goes hand in hand with the cultures, is rapid antibiotic administration. Broad spectrum antibiotics, meaning they target a wide range of common bacteria, must be given within 60 minutes of sepsis recognition. This means now, not when it's convenient for the next medication round. The clock is truly, truly ticking.
And then we're talking about supporting the body itself, right, with fluids, because sepsis causes blood vessels to dilate and blood pressure to plummet.
Yes. Third is fluid resuscitation. If the patient's mean arterial pressure or MAP, that's basically the average pressure pushing blood through their organs, is below 65, or if their lactate level is 2 or higher, clinicians immediately administer a rapid intravenous fluid infusion. This is typically a crystalloid bolus of 30 milliliters per kilogram of body weight. It's important, as the module notes, to use balanced solutions like lactated ringers to avoid complications like hyperchloremia. That's excess chloride, which can happen with normal saline and actually worsen kidney function. These fluids help restore the blood volume and support blood pressure.
What about lactate? I know that's a big indicator in sepsis. Why is it so important to keep monitoring it?
Fourth, lactate monitoring is essential. Yeah, lactate is a chemical produced when the body isn't getting enough oxygen to its tissues. You measure the initial lactate level, and if it's elevated, you recheck it frequently. A rising trend or a failure for it to come back down towards normal is a critical signal of ongoing tissue hypoperfusion. That means the organs aren't getting enough blood flow and oxygen. It strongly predicts worsening organ dysfunction. And finally, fifth, if fluids alone aren't enough to restore perfusion and get that map back up to 65, vasopressor consideration comes into play very quickly. Vasopressors are medications that constrict blood vessels, kind of like tightening a hose to bring blood pressure back up and get blood flowing where it's desperately needed. Specifically, early initiation of norepinephrine, a common vasopressor, should be considered to prevent prolonged low blood pressure.
It sounds like a lot of these critical first steps are actually taken by the frontline healthcare providers, especially nurses. They're often the ones identifying the problem and kicking off this whole process, aren't they?
They absolutely are. Nurses are often the ones at the very front lines. They recognize the early subtle signs and they initiate these crucial steps of the bundle. Sometimes, even before full physician orders are in place or before a diagnosis is fully confirmed, their pivotal role in activating this bundle and driving these rapid interventions cannot be overstated. They are the constant watchful eyes.
So once that golden hour bundle is in motion, antibiotics are going in, fluids are running. How do clinicians really unmask this invisible enemy? What are the diagnostic tools they use, and how do they differ in a trauma patient who already has so many overlapping symptoms and issues going on?
This is where diagnostics become a highly nuanced art, especially in the chaotic context of trauma. Module 4 emphasizes that we rely on core labs, but interpreting them requires a very special lens. You're looking at essential panels like a complete blood count, CBC, checking red and white blood cells, a comprehensive metabolic panel, CMP, looking at kidney and liver function, electrolytes, lactate, of course, and a coagulation panel to assess blood clotting.
But you mentioned earlier that single lab values can be really misleading in trauma. Can you elaborate on that? Why isn't a single number enough to go on?
Absolutely. A single elevated lactate, for instance, could be from the shock of the trauma itself or even from severe pain. It doesn't automatically mean sepsis. Similarly, leukocytosis, a high white blood cell count, is also expected after significant trauma just due to the body's massive stress response. It doesn't automatically scream infection. What's far more valuable, particularly in the trauma context, is the trend of these values over time. So, are they rising rapidly? Are they failing to normalize despite interventions? That's the real clue, the story the labs are telling when you look at them together over hours or days. We also look at procalcitonin, or PCT. It's a protein that serves as a more reliable marker for bacterial infection compared to just WBC count. But even PCT needs to be trended as it can initially increase with trauma alone. And critically, watching for subtle upward shifts in markers like INR, that's a measure of blood clotting, or creatinine signaling kidney function changes, can be early signs of organ compromise from sepsis.
Okay, what about imaging? You can't just put every critically injured trauma patient into a big CT scanner and move them around constantly, right? That seems risky.
You're exactly right. Choosing the right imaging depends entirely on the patient's stability. If a patient is unstable, meaning their blood pressure is critically low, they're rapidly deteriorating, you start with bedside tools. A focused assessment with sonography for trauma or fast exam, that's a quick ultrasound done right at the bedside. Or general point of care ultrasound POCUS, these can rapidly detect things like free fluid in the abdomen, maybe indicating bleeding, or a pneumothorax, a collapsed lung, without having to transport a critically ill patient, which is dangerous in itself. Now, for stable patients, you can then escalate to a CT scan of the chest, abdomen, and pelvis. This is crucial for localizing potential sources like hidden abscesses, bowel leaks, or pneumonia. But here's the critical rule, the mantra almost: imaging never delays antibiotics. The elements of the golden hour bundle, including those vital antibiotics, run in parallel with diagnostic efforts. You do both at the same time.
It sounds like there are clear moments when diagnostic findings demand urgent action. How do nurses, for instance, who are constantly at the bedside, trigger that action and make sure the whole team is aware of the urgency?
They absolutely do. When diagnostic findings demand urgent action, we call them escalation triggers. A lactate level above 4 or 1 that's rapidly rising despite fluids. New findings on a CT scan, like an abscess or free air in the abdomen, worsening kidney or clotting function, all these demand immediate attention. Nurses must clearly communicate these findings, often using a structured communication tool like SBAR situation, background assessment recommendation. This provides a clear, concise way to relay critical information and advocate powerfully for immediate consults with the ICU teams, surgical teams, or infectious disease specialists. It's about translating those observations and data points into urgent calls to action.
I can see how that takes incredible clinical judgment in the form to connect all those dots: the patient's appearance, the vitals, the labs, the trends. Is there an example that illustrates how this bedside vigilance combined with diagnostics really drives life saving decisions?
Yeah. Module 4 provides a powerful case snapshot. A 32-year-old male, multiple fractures. His initial lab results were ambiguous. White count borderline, lactate slightly up, but not dramatically. However, the nurse observed him closely. She saw a rapidly increasing heart rate, a drop in blood pressure, and a new subtle change in his level of consciousness. He just wasn't quite right. She didn't wait for a definitive lab report or for imaging results to come back. Her strong advocacy pushing for antibiotics, despite the delayed imaging and the initially ambiguous labs, proved to be life saving. This just perfectly illustrates how integrating those bedside observations, the human element of keen observation with lab trends, and the overall clinical picture drives those critical time sensitive decisions. It's not just about the numbers, it's about the whole story the patient is telling you.
Okay, we've talked about fluids and antibiotics, that initial rapid fire response, but what happens when those aren't enough to stabilize a patient, when their blood pressure just stubbornly refuses to come up? When does the treatment path shift to something, well, even more potent?
This is where we see a crucial transition to vasopressors, as detailed clearly in Module 6. If after that initial rapid fluid infusion, that 30 milliliters per kilogram crystalloid bolus, the patient's mean arterial pressure remains stubbornly below 65, vasopressors are indicated. It's really vital to stress that these are not a last resort, something you only use when a patient is practically circling the drain. Number. Waiting too long for them can lead to irreversible tissue hypoxia, meaning not enough oxygen getting to the tissues and widespread organ dysfunction. The moment those fluids aren't cutting it, you have to act decisively.
So, vasopressors are powerful medications. What's the preferred agent in these situations? I imagine there are choices.
There are choices, but the first line agent is overwhelmingly norepinephrine, often known by its trade name Levophed. It's chosen due to its potent vasoconstrictive properties. It effectively constricts blood vessels to raise blood pressure. And importantly, it has minimal problematic side effects compared to, say, dopamine, another vasopressor. Dopamine is generally avoided in sepsis due to its higher risk of causing dangerous heart arrhythmias. So, norepinephrine is really the go to, the precision tool for blood pressure support in sepsis.
Okay. So, once a patient is on these powerful medications, which are often given through a central line because they can be so irritating to smaller veins. What does the nursing team need to keep a constant close eye on? What are the key monitoring points?
Nursing monitoring becomes incredibly intense and constant. Absolutely. Continuous monitoring of MAP is paramount. Urine output is critical. It tells you if the kidneys are getting enough blood flow. And mental status is a key indicator of brain perfusion. These are real time indicators of how well the body is responding. They also have to watch closely for signs of vasopressor complications, things like extravasation. That's where the medication leaks out of the vein into the surrounding tissue, which can be very damaging, or peripheral ischemia, which manifests as cold mottled extremities, signaling that blood flow isn't reaching the furthest parts of the body. A central line, a catheter placed in a large vein, is always preferred for administration to minimize these risks and ensure the medication reaches the bloodstream quickly and reliably.
This sounds like another one of those moments where timely decisions really make a dramatic difference. Is there an aha moment or a specific case study that illustrates this immediate impact of using vasopressors early versus delaying?
Yes. Module 6 highlights a really compelling case study comparing early versus delayed vasopressor initiation. It involved a 56-year-old male post motor vehicle collision, pelvic fracture, liver laceration. In the scenario where norepinephrine was initiated early, within just 40 minutes of fluids failing to bring his blood pressure up, the patient stabilized quickly. His lactate levels decreased, and he actually avoided needing intubation. In stark contrast, when initiation was delayed for over 2 hours, the patient's lactate levels rose significantly. His Glasgow Coma Scale score, that measure of consciousness, dropped, and he required intubation for encephalopathy, brain dysfunction due to the sepsis. He also had a much longer ICU stay and developed renal dysfunction. This case powerfully reinforces that timely initiation of vasopressors dramatically improves outcomes. It's not about waiting for a patient to completely crash. It's about anticipating that need and intervening before irreversible damage occurs.
So we're stabilizing the patient's blood pressure with fluids and maybe pressors. We're giving antibiotics to fight the infection throughout the body. But if there's a lurking infection, a specific source where the bacteria are originating or hiding out, it needs to be found and dealt with directly. This is where source control comes in, right?
Exactly. Source control is the crucial, often surgical partner to antibiotics. You really can't have one without the other for effective treatment. Think of it this way: antibiotics are like an army trying to defeat an invading force spread across a wide battleground. But if the enemy has a hidden stronghold they keep returning to, a base from which they continuously launch attacks, the battle will never truly end. The infection source must be physically eliminated. Without it, antibiotics might only suppress the infection, temporarily holding it at bay, but they probably won't cure it. This leads to persistent infection, worsening organ failure, and far, far poorer outcomes.
What are the common hideouts for these infections in trauma patients? Where do clinicians typically look for the source of the problem? In trauma, the sources are often directly related to the initial injury or the subsequent medical interventions needed. We're talking about areas like open fractures where the bone broke through the skin, surgical wounds that become infected post op.
Really nasty things like necrotizing soft tissue infections, those flesh eating bacteria that rapidly destroy tissue, intra abdominal abscesses, which are pockets of pus hidden inside the belly, infected hematomas, collections of clotted blood that become infected, and importantly, any retained foreign bodies. This crucially includes invasive devices like urinary catheters, central lines, and especially that orthopedic hardware we mentioned: pins, plates, external fixators that can become colonized with those antibiotic resistant biofilms.
And how do clinicians actually go about controlling these sources? Is it always a major surgery?
Not always a major open surgery, no, but often it requires an invasive procedure of some kind. Methods of control include surgical debridement. That's the physical removal of dead or infected tissue. Or maybe a laparotomy, an open abdominal surgery for conditions like peritonitis, widespread infection in the abdomen, or a bowel leak. But non surgical methods are also critical. Things like percutaneous drainage of abscesses, where a needle is guided by imaging like CT or ultrasound to drain the pus without a large incision. And very importantly, the removal of any suspected infected hardware or lines, because even the best antibiotics struggle to clear bacteria living on these foreign materials.
And this, I assume, is also incredibly time sensitive, just like everything else in sepsis care.
Extremely time sensitive. The time imperative for source control is a critical determinant of survival. Research clearly shows that delays beyond 12 hours, especially in unstable patients, significantly increase the mortality risk. Every minute that infection source remains uncontrolled, the patient is at greater risk of widespread organ damage and ultimately death. It really is another race against the clock.
So, nurses, again, must be incredibly attentive here, right? Identifying clues that suggest there's still an uncontrolled source fueling the fire, even while other treatments are ongoing.
Absolutely. It's a key area for nursing vigilance and advocacy. Nurses are often the first to recognize those persistent signs of uncontrolled infection, things like an ongoing fever despite appropriate antibiotics, a rapidly rising lactate level even after fluid resuscitation, new purulent drainage from a wound, or increasing abdominal distension and tenderness. They are absolutely key in advocating for early imaging, like getting that urgent CT scan and pushing for prompt surgical consults. They connect the dots between the subtle bedside signs and the need for immediate definitive action to get the source controlled.
Can you give us a concrete example of that kind of intervention making a difference where timely source control truly changed the outcome for a patient?
Yeah. Module 5 shares the compelling case of Mr. J. He was a 58-year-old male. Rib fractures, abdominal bruising after a motorcycle crash. In the timely intervention scenario, keen nursing recognition of his rising lactate and increasing abdominal distension led to an emergent laparotomy, that abdominal surgery, within just 6 hours. They found an infected collection, drained it. This rapid source control resulted in his stabilization and a relatively short 4-day ICU stay. Now, contrast that with the delayed response scenario, a 36-hour delay in intervention, perhaps due to initial ambiguous symptoms or delays in getting imaging. This led to his abscess rupturing internally. He spiraled into septic shock and multi organ dysfunction syndrome, MODS, where multiple organs fail. This required a grueling 17-day ICU stay, prolonged ventilation, and a far more arduous recovery. It powerfully illustrates the direct life or death impact of timely source control, often triggered by that crucial initial nursing observation and advocacy.
So let's say a patient survives the acute life threatening phase of trauma induced sepsis after all those interventions, the antibiotics, the fluids, the source control, the ICU stay. The battle isn't over then, is it? It sounds like there's a whole new set of challenges awaiting them even after they leave the ICU, maybe even leave the hospital.
That's very true. Surviving sepsis is often just the beginning of a challenging and frequently invisible journey. We often talk about post sepsis syndrome because recovery extends far beyond ICU discharge, sometimes for months, years, or even for some, a lifetime. Survivors often face this constellation of long term issues that can severely impact their quality of life.
What kind of issues are we talking about? Both physical and mental, I imagine. The body and mind have been through such a profound shock.
Exactly. Physically, they can experience profound fatigue, not just tired, but a crushing exhaustion that's disproportionate to their activity level and doesn't just go away with rest. They also often develop something called ICU acquired weakness. Their muscles significantly weaken from prolonged bed rest, inflammation, maybe medications used during critical illness. This severely impairs their mobility and their ability to perform basic daily functions. Cognitively, many survivors struggle. Memory loss is common, what patients often describe as brain fog, difficulty concentrating, problems with planning or decision making. These cognitive impairments can be incredibly frustrating and debilitating, affecting work, relationships, everything. And emotionally, there's a significant burden. Anxiety, depression, and even post traumatic stress disorder, PTSD, are unfortunately common, especially if they experience delirium, that state of severe confusion and hallucinations, or had extended periods of sedation during their critical illness. These are often the invisible burdens, right? The scars that are harder to see than a surgical incision, but just as debilitating, sometimes more so.
And does this often lead to them coming back to the hospital even after they've been discharged?
Unfortunately, yes. There's a high readmission risk. Studies show up to 30% of sepsis survivors are readmitted within just 30 to 90 days of discharge, often due to recurrent infections because their immune system may still be recovering or other complications directly related to their sepsis episode and the overall trauma. It can become a really vicious cycle that prolongs their suffering and recovery.
So, what's being done to help them on this long and often difficult road? Are there specific rehabilitation strategies or maybe new models of care emerging to support these survivors?
Yes, thankfully. And they're crucial for improving long term outcomes. Rehabilitation strategies really focus on a holistic approach. Early mobility, even beginning while they're still in the ICU, is vital to prevent or mitigate that ICU acquired weakness. Cognitive rehabilitation and neuropsychological screening help address the brain fog and memory issues. Proper nutrition support and strategies for sleep regulation are also critical for systemic healing and recovery. What's truly exciting, though, is the emergence of new models of care specifically focused on sepsis survivorship. We're seeing specialized post ICU or sepsis recovery clinics pop up. Telehealth follow up is becoming more common, where patients can consult with specialists remotely. Even digital symptom tracking apps are being developed. These offer coordinated multidisciplinary care. They bring together physical therapists, PT, occupational therapists, OT, psychiatrists, psychologists, and dedicated care coordinators under one roof or virtually to provide comprehensive tailored support.
That sounds incredibly comprehensive, addressing not just the physical, but the mental and emotional toll as well. What about the people supporting them day to day? The family members, the caregivers, they must bear a significant burden too.
You've hit on a critical point and one that's often overlooked in the system. The unsung heroes are often the caregivers, typically family members, and they bear a significant, often invisible burden themselves, leading to high rates of burnout, anxiety, and depression. They need education on red flags to watch for after discharge, on realistic functional milestones to expect during recovery, and most importantly, they need support for themselves, whether it's through support groups, counseling, respite care. Their well being is intrinsically linked to the patient's recovery. You can't separate the two.
Can you give us an example of how these new models of care might impact both the patient and the caregiver, offering that crucial long term holistic support?
Sure. Module 11 details a powerful case study. A 42-year-old male trauma survivor experienced persistent memory loss, profound fatigue, and significant anxiety after his battle with sepsis. He couldn't return to work, felt isolated. His spouse, who was his primary caregiver, was struggling significantly with burnout, feeling completely overwhelmed and unsupported. Access to a specialized post sepsis recovery clinic provided him with targeted cognitive rehabilitation exercises, access to peer support groups where he could connect with other survivors who truly understood, and vital care coordination that linked him seamlessly to various specialists he needed. This comprehensive, ongoing approach not only significantly improved his reintegration into daily life and boosted his morale, but it also dramatically reduced the strain and stress on his caregiver. It truly showcases the immense value of coordinated long term support that extends well beyond the hospital walls.
Okay. Beyond the purely medical and rehabilitative challenges, there are also these systemic issues that can impact care. I'm talking about the human element and specifically how implicit bias, those unconscious attitudes we all carry, can affect something as critical as sepsis recognition and treatment. How it might impact whether someone gets that life saving golden hour bundle they desperately need.
This is an often uncomfortable truth, but it's absolutely essential to address head on. Module 10 clearly outlines that implicit bias can significantly affect clinical decision making. These are unconscious attitudes or stereotypes that can influence our understanding and decisions without us even realizing it, even in high stakes environments like trauma care. Studies, for example, have shown that pain is often underestimated in Black, Indigenous, and people of color. This can tragically lead to delays in administering crucial pain medication, but also delays in recognizing serious conditions like sepsis if symptoms are dismissed, or delays in crucial antibiotics and other life saving interventions. Similarly, other studies suggest women and minority trauma patients face an increased risk of undertriage, meaning their injuries are initially deemed less severe than they actually are, delaying critical care.
How do we ensure the patients receive the care they need? The same high standard of care, regardless of their race, ethnicity, gender, or how they're perceived by the staff.
It requires a deep, ongoing commitment to cultural competency within healthcare. That's more than just awareness. It's actively practicing approaches that respect diverse health beliefs, values, and communication styles, ensuring that a patient's cultural background doesn't create unintentional barriers to care. A critical component, especially in multilingual settings, is the absolute importance of using professional medical interpreters. We really cannot stress this enough. Relying on family members, even older children, for translation, while often well intentioned, can lead to serious inaccuracies, misunderstandings about complex medical information, and it compromises patient autonomy and their ability to give truly informed consent. Professional interpreters ensure accuracy, confidentiality, cultural nuance, and genuinely patient centered care.
So, beyond individual education and cultural competency training, are there practical tools or maybe systemic strategies that can actually help mitigate this bias in the fast paced, high stakes environment of trauma and sepsis?
Nate, I like your thinking here.
Can we build systems that are inherently more equitable?
Yes, and this is where protocols act as crucial safety nets. Standardized sepsis protocols and care bundles, like the Golden Hour bundle we discussed, are designed precisely to create a uniform structure for a response. This standardization can directly mitigate the impact of individual unconscious biases by taking some of the subjective judgment out of the initial steps. Checklists, for instance, reduce variability in triage, diagnostics, and treatment initiation. They act as powerful tools for advocacy for nurses, for example, ensuring that all patients, regardless of their background or how they present initially, receive the same evidence based care in a timely manner. They standardize the process, making it less susceptible to individual interpretation or assumptions. Additionally, regular team review of outcomes data, specifically looking at it broken down by patient demographics like race and ethnicity, can help identify and proactively address disparities that might otherwise go completely unnoticed.
Can you give us an example of how a protocol like a sepsis checklist could actually intervene to counteract bias in a real patient scenario? How it might make a tangible difference?
Module 10 provides a really powerful case study here. A 55-year-old Latina woman arrived after a motor vehicle collision. She had clear signs concerning for sepsis, hypotension, low blood pressure, and altered mentation confusion. Despite these objective clinical concerns, her symptoms were initially attributed by some staff members to a language barrier and baseline anxiety. Assumptions were made. This led to a dangerous delay in recognizing potential sepsis and administering antibiotics. It was a diligent nurse utilizing a standardized sepsis checklist as part of their workflow who flagged the vital sign abnormalities and the delay. She pushed for a critical reassessment. This prompt led to the rapid activation of the sepsis bundle, timely antibiotics, and appropriate interventions. This case powerfully illustrates precisely how structured protocols, when used equitably and with vigilance by the team, can override unconscious assumptions and ensure timely life saving care for everyone. They act as a crucial safeguard against bias.
Okay, it's abundantly clear from everything we've discussed that managing trauma induced sepsis from the moment of injury right through to long term recovery is far too complex for any single individual, no matter how skilled. It really is a profound team sport, isn't it?
Absolutely. The power of the team is paramount in trauma informed sepsis care. Module 9 really highlights this. Effective interdisciplinary collaboration isn't just a nice to have or some buzzword in healthcare. It's absolutely essential for improving patient outcomes, reducing errors, and navigating this complexity. Each team member brings vital specialized contributions that are indispensable.
So, who are the essential players on this team, and what unique perspective or expertise do they each bring to the table in a complex trauma and sepsis scenario?
It's truly a symphony of expertise working in concert, or at least it should be. Nurses are often the primary care coordinators and patient advocates. They're constantly at the bedside, noticing subtle changes, anticipating needs, implementing the plan. Physicians typically lead the diagnostic process and treatment decisions, guiding the overall medical plan, making those critical calls on interventions. Social workers address crucial psychosocial aspects, assessing the patient's support system for discharge, helping navigate insurance issues, addressing emotional and financial burdens on the patient and family. And then you have the diverse allied health professionals. Physical therapists and occupational therapists are vital for functional recovery and mobility starting early. Respiratory therapists manage breathing support, crucial in sepsis, and pharmacists ensure medication safety, appropriate dosing, help with antibiotic selection, and stewardship. Each role is critical and deeply interconnected. Like cogs in a complex machine, they all need to work together smoothly.
How do all these different professionals, with their varying schedules, priorities, maybe even different ways of communicating, talk to each other effectively, especially in such a fast paced and high stakes environment where every minute matters?
That's where structured communication tools become absolutely indispensable. You can't just rely on casual hallway conversations. Tools like SBAR, Situation Background Assessment Recommendation, provide a clear, concise, and structured way to communicate critical information during handoffs, minimizing misunderstandings and ensuring vital details aren't missed. Daily huddles, even brief ones, and formal interdisciplinary rounds foster real time alignment and shared decision making. They ensure everyone is on the same page about the patient's evolving condition, their progress, the goals of care, and the plan for the day or for discharge. Shared electronic health records, when used effectively, also ensure team wide visibility of documentation, orders, and care plans, so everyone should have access to the most up to date information.
But I can imagine there are always challenges to achieving this ideal teamwork. What common barriers do teams face that can hinder this seamless collaboration and potentially impact patient care?
Many teams grapple with common challenges. Role ambiguity is a big one, where responsibilities aren't clearly defined. This can lead to delays, duplicated work, or even critical omissions because everyone assumes someone else is handling a particular task. Hierarchical barriers can be a major issue. These can inhibit team members, particularly those lower in the traditional hierarchy or perhaps those who feel less confident from speaking up, even when they spot critical issues or have vital information to share. Fear of challenging authority, even subtly, and unstructured handoffs where information is passed along informally, maybe incompletely, or without opportunity for questions are a well known and dangerous cause of errors and misinformation, leading directly to patient harm sometimes.
So, what are the solutions to these barriers? How can teams actively foster better collaboration? And how does that directly lead to better patient outcomes and a smoother patient journey?
The solutions really involve actively fostering a culture of psychological safety and structured collaboration. Interprofessional training, where different disciplines learn together, maybe through simulations, and practice communication skills like SBAR improves mutual understanding and respect. Clear delegation of tasks and consistent use of protocols and checklists reduce role overlap and uncertainty. Everyone knows their part. These efforts directly translate into improved collaboration, a significant reduction in medical errors, and ultimately enhance patient trust and dramatically better outcomes. When the team works like a well oiled machine, communicating effectively and respecting each member's contribution, the patient benefits immensely at every stage.
Can you share a real world example of how these elements come together or maybe sometimes fail to, and the impact that has on the patient's experience?
Sure, Module 9 provides a relevant case study, maybe less dramatic than sepsis itself, but an example of communication breakdown. A 28-year-old motor vehicle collision survivor was medically ready for discharge, but his recovery required coordinated outpatient physical therapy and counseling appointments to be set up before he left. The nurse, who was understandably busy with acute patient care tasks, assumed the social worker and the physical therapist were fully informed about these specific outpatient needs and just proceeded with the basic discharge planning paperwork. However, they weren't fully looped in on the specifics or the urgency. This led to a delayed transport for the patient, confusion about follow up, and a fragmented, stressful start to his outpatient care. After a post event review, a lessons learned moment the team learned from the misstep, they instituted a brief daily team huddle where all key disciplines involved in discharge planning gathered to review patient progress and specifically discuss discharge needs and coordination. This small, consistent change significantly improved communication by clarifying roles, ensuring proactive coordination among everyone involved. It led to much smoother patient transitions and better continuity of care. It's a powerful illustration of how consistent, clear communication impacts every single step of the patient's journey.
We've covered so much ground today. From that initial terrifying impact of a traumatic injury to the stealthy and often invisible threat of trauma induced sepsis, through the critical moments of early detection, the golden hour interventions, all the way to the complex and often unseen journey of long term recovery. And we've truly highlighted the vital role that seamless teamwork and equitable, unbiased care play every single step of the way. It's not just one piece, it's everything together.
It's been an intricate journey into a condition that truly tests the limits of healthcare and the human body. What's most fascinating here, I think, is how trauma induced sepsis serves as this microcosm of modern healthcare complexity. It really illustrates the intricate interplay of the body's own biological response gone awry, the critical need for timely human intervention, the application of technological tools, and the profound impact of those human factors like unconscious bias and interdisciplinary collaboration.
What truly stands out to me is that realization that every single minute, every subtle observation at the bedside, every team interaction, every conversation genuinely matters. The consequences of even slight delays or misinterpretations can be devastating, highlighting just how fragile and interconnected the system and the patient's condition really is.
That's the core insight of this podcast, isn't it? And considering how pervasive traumatic injury is globally and how stealthy and devastating sepsis can be once it takes hold, especially in these vulnerable patients, it raises an important question for all of us. For you, our listener, what societal shifts perhaps in public health awareness, maybe policy changes, or what technological innovations do you think will make the biggest difference in protecting the most vulnerable patients from this hidden danger? How can we ensure truly equitable and holistic care for everyone, regardless of who they are or how they present?
That's a powerful thought to leave you with. We encourage you to continue your curiosity in your own understanding of health for yourself, daily in your nursing practice, and advocate for systems that prioritize rapid, informed, and truly compassionate care for every single patient every single time. Thanks for listening to the Confident Nurse Podcast.
Don't let license renewal sneak up on you. Get your accredited CE courses, printable study guides, and quick quizzes to lock it in. Download certificates instantly, finish your hours, feel confident, and get back to life. ConfidentNurse.com.